Good morning. During my allotted time, I'm going to review the pathophysiology of gas embolism during cardiopulmonary bypass. I will report the clinical incidence, describe three major categories, and give examples of specific etiologies, including some newer causes of gas embolism during cardiac surgery. I'll touch on methods of prevention, and finally some treatment regimens that have been reported in the literature. I will not be addressing gaseous microemboli during this talk, other than to say that they, of course, occur every time cardiopulmonary bypass is used, but are far less damaging to the patient than gross air embolism. There are some premises in my talk, the first of which is that gross air embolism is almost always iatrogenic. Much has been learned, however, about how to minimize this risk during cardiac surgery, which is the major message I wish to convey today. I think if you look at the various sources of air during cardiac surgery, there are really three disciplines involved, and this is the second premise. There is surgical air, there is pump air, and there is anesthetic air. Surgical air and its causes and prevention constitute the largest number of articles in the published literature. Massive air embolism from the pump has decreased dramatically in recent decades, and the risk of air being introduced into the patient by the anesthetist is almost always a very rare occurrence today, with check valves, collapsible bags, that sort of thing. So a third premise of my talk is that working together, all three disciplines can certainly prevent iatrogenic gas embolism. I'll now review the pathophysiology of all three categories and touch upon factors such as rate and site of entry, the organ or tissue bed that is affected, the volume, and finally the gas composition. Well, as you all might know, venous gas embolism is better tolerated than arterial due to the filtering capacity of the lungs. Arterial gas embolism, on the other hand, causes mechanical blockage of blood flow, typically at the arteriolar level. With venous gas embolism, large amounts that is, one typically gets right ventricular outflow obstruction. In essence, the right ventricle becomes deprimed and continues to beat. And when this occurs, especially with large volumes of venous air, there's a phenomenon that's been described as the mill wheel murmur that is quite strong and has been described many times in the literature. For lesser amounts of venous air, one typically sees pulmonary hypertension, and it's been shown by Butler and colleagues many years ago that about 0.3 cc's per kilo per minute can be filtered indefinitely by the lungs. That was not good, sorry. For arterial air embolism, there was a good study done that predated cardiopulmonary bypass by Dr. Chase. He published this in 1934 after going to the laboratory and injecting various amounts of air into rabbits' arterial side. He was prompted to go to the laboratory and do this because he had a patient that experienced air embolism, and he wanted to study the physiologic effects. The physiologic effects that he described in sequence consist of initially a vasoconstriction, decrease in blood flow, the development of progeny bubbles, that is, larger bubbles dividing into smaller bubbles, or in some cases, small bubbles coalescing with other bubbles and becoming large bubbles. The bubbles, as you might imagine, are carried by the bloodstream to smaller and smaller vessels until they finally stop blood flow in the affected vessel. And this is followed by a vasodilatation and a reactive hyperemia once the bubbles resolve. So during cardiac surgery, it's fairly obvious that gas embolism to the coronary or to the cerebral circulation pose the greatest threat. Coronary artery gas embolism often can be seen and removed while the patient is still on bypass. And the right coronary artery, because of its anatomic location uppermost in the supine patient, is the site where many bubbles lodge, particularly after open heart procedures, valve procedures where the chambers have been opened. Cerebral air embolism is often insidious and will not manifest its pathophysiology quite often until the postoperative period. The rate of entry and volume are important determinants of the pathophysiology, and as you might expect, the faster the entry and the larger the volume, the greater the risk of an adverse outcome. Cardiopulmonary bypass is capable of introducing large amounts very rapidly into the patient because of the vascular connections to the extracorporeal circuit. Gas composition is also very important, with air bubbles being the longest lived in the circulation because of solubility coefficients. It's been demonstrated experimentally that a 4 millimeter bubble of air will persist for up to 560 minutes in the circulation, whereas if that 4 millimeter bubble were composed of oxygen, the lifespan would be 1/10 or about 56 minutes. Professor van der Linden will be addressing carbon dioxide embolism shortly. Other pathophysiologic effects are that bubbles in blood are a foreign surface, and typical blood bubble interactions consist of platelet aggregation, white blood cell activation, and protein denaturation, all of which can trigger microthrombus formation that will persist and cause pathology after resolution of the bubbles. Now this transmission electron micrograph from Albertine shows an air embolism in sheep blood after 4 hours. And what one sees at the arrows is the accumulation of white cells at the bubble blood interface. And finally, there are some pathologic effects of bubbles on the vascular endothelium that can irritate the endothelium and cause increased vascular permeability, protein leakage, and tissue edema. Importantly, these endothelial effects are responsible in some cases for a breakdown in the blood-brain barrier in the case of cerebral air embolism. Now, what is the known incidence of gas embolism during cardiopulmonary bypass? Well, fortunately, we now have the benefit of several national surveys that have been conducted over the last 3 decades to give us a hint or give us some clues as to the incidence of air embolism. And the good news is that the incidence is very low. These 2 bar graphs compare 5 surveys, the first being the pioneering survey by Stoney and colleagues in the 1970s. There was a study in the UK by Wheeldon. Our group did a study in the mid-1980s. There was an Australasian survey done by Jenkins. And finally, Mijak and colleagues in the United States did a survey on the incidence of air embolism. The orange bars show number of incidents of air embolism per 1,000 cases, and the red bars indicate an adverse patient outcome. An adverse patient outcome was defined in various ways as to prolonged hospital stay, permanent injury, or death in most of the surveys. So the top graph shows overall incidence for gas embolism, and I think you can see that the trend for occurrence tends to be going down. I think that the aberration here from Jenkins was that the question was worded very broadly, and I don't think that's a typical finding today. The other important thing is that adverse outcomes overall have gone way down. The lower graph addresses a specific air embolism accident, namely reversal of the left ventricular vent line, and again, the incidence has gone down to negligible levels. For that survey by Mijak, shown on the right, the incidence was 1 in every 1,500 cases, and then for an adverse outcome, it was 1 in 33,000 cases. Now, I should tell you that there's been an additional survey by Charrière and colleagues in France for the year 2005, and he showed even lower incidences that are shown here for mishaps with air embolism during the pump. So what are some common mechanisms of gas embolism during cardiac surgery? This pie chart shows information from our survey in the mid-1980s, and I would tell you that it is a bit dated, but I think that when one looks at the various ways air got into the patient, at least during that era when bubble oxygenators and membranes were used about 50% of the time each, these were the major mechanisms. Inattention to reservoir level, shown in pink, was responsible for more than 2/3 of the reported incidents. There were 284 incidents of air embolism reported on our survey, and the cause was attributed to inattention to the reservoir level, where gas is drawn from the circuit and pumped into the patient. The second most common category, which really was underappreciated at the time, was aortic root air during the administration of cardioplegic solution, about 29% of the cases. Two other major causes of gas embolism reported by our group was unexpected heartbeat and reversed LV vent line, both comprised about 10% of the cases. On the previously mentioned Charrière survey in 2005, aortic root air from cardioplegia administration was shown to occur about once every 2,000 cases. Now, what are some newer mechanisms of gas embolism? Well, as you might expect, as new surgical techniques and new cardiopulmonary bypass equipment has been developed and evolved, newer mechanisms of getting air into the patient have evolved as well. First, vacuum-assisted venous drainage, which is in vogue right now in many centers, has been shown to favor the entrainment and the entrainment of air at the venous cannulation site, and it can exacerbate the formation and transmission of gaseous microemboli. It's important to remember that just because there's a membrane oxygenator downstream and an arterial line filter, these two devices won't remove all the GME that are produced by VAVD. A potentially lethal mechanism when using VAVD occurs when the hard shell reservoir has vacuum applied either before starting bypass or after bypass has been stopped. And this can lead to air being drawn into the arterial side of the circuit through the membrane oxygenator or arterial filter. More dramatically is if vacuum is applied to the sealed reservoir, vacuum is lost, and the pump suckers continue to pump air and blood into that sealed reservoir. This typically occurs before starting bypass, and at the instruction from the surgeon to begin bypass when the venous clamp is removed, one can witness what's been described as an explosive retrograde air going back up the venous line and directly into the patient's heart, and this is a very serious complication. Air embolism using mini bypass systems have also been implicated in air embolism. As you may know, many of these mini bypass systems have no venous reservoir, and the transit times of blood through the extracorporeal circuit is quite rapid. Manufacturers have developed various so-called air eliminators to deal with entrained venous line air, but these devices can be overwhelmed, and they again will increase GME counts on the arterial side of the circuit and even can lead to gross air embolism in the arterial side. So how can gas embolism be minimized during bypass? Well, I think there's several ways that have been described. Safety devices on the CPB circuit, of course, have become much more accepted than they were 20 or 30 years ago. Certainly the development of techniques or protocols by the cardiac surgery team can reduce this risk. Thorough cardiac de-airing by all three of the disciplines, especially after valve procedures, that is then verified by transesophageal echocardiography, is very important. I'll talk about that in a little more detail shortly. And finally, effective communication can lead to reduction of the risk. What about safety devices? Well, for the perfusionists in the audience, I'm sure there's nothing particularly new here, but level alarms, air bubble detectors. There's one machine now that has the capacity for 2 or 3 air bubble detectors on the circuit. I think based on the previous information, it would be wise to put that on the cardioplegia delivery line. Vented arterial line filter, of course, has been talked about and studied for many, many years. One-way valves, either after the centrifugal pump or on smaller lines, are effective to prevent air embolism, and use of a centrifugal pump can prevent pumping of massive air embolism. Now, what about some techniques? Pre-bypass checklists can uncover errors before starting bypass that would otherwise potentially lead to gas embolism. Vents should be tested for proper operation before they're used to actually vent air or blood from the heart chambers. And finally, for the surgeons in the audience, I think it's important that they notify the perfusionist when vents are either placed or removed, because this can affect how the bypass is managed. Other techniques include ensuring an air-free and leak-free venous cannulation site. Some groups have advocated putting a shunt between the arterial and venous tubing that will allow for the quick removal of any air that gets into the arterial side, or at the end of the case, if any air is in the circuit. It's a convenient way to shunt the air over to the venous side. And finally, confirming that the arterial cannula is bubble-free before reinfusion of perfusate, I think, is important. Now, this drawing shows the typical location of air that sometimes accumulates at the uppermost part of the arterial cannula following bypass. And I would tell you that this can occur even after coronary artery bypass operations, or so-called cases where the heart is not technically opened. So it's always a good idea to confirm with the surgeon or his assistant that the cannula is bubble-free before reinfusing any perfusate. De-airing very, very important, probably the most coordinated effort that's needed during cardiopulmonary bypass is at the end of the case to de-air the heart. And there are many, many techniques that have been described over the years. I'm not sure every surgical team practices in the same way, but techniques that have been described consist, of course, of venting, ballottement of the left ventricle, shaking the heart, elevating and massaging the heart by the surgeon. The perfusionist will be asked to fill and empty the heart or increase or decrease the CPB flows. And from the anesthesiologist perspective, lung ventilation or relaxation is very helpful in removing trapped air, and putting the patient in steep Trendelenburg, of course, is also used. This figure shows where air typically accumulates in the right upper pulmonary vein. Air not effectively removed from this site can then go into the left atrium, left ventricle, where more air can collect in the apex, and if not removed, can be ejected out the aorta. What if the worst case scenario occurs? What if you have a massive air embolism? Well, bypass should be stopped immediately. The source of air needs to be identified, and the air needs to be removed. Air can be removed sometimes by direct aspiration, either from the circuit or from the patient. The second technique that's been described by Dr. Noel Mills in 1980 is called retrograde cerebral perfusion, where the arterial cannula is inserted into the superior vena cava. Flow at about 2 liters per minute occurs. The aorta is opened, and during retrograde cerebral perfusion, the anesthesiologist may be asked to compress the carotids to also force air through the vertebral systems. Now, there have been many, many case reports in the literature since 1980 describing how effective retrograde cerebral perfusion has been, and many patients have made uneventful recoveries after this. From our own survey, there were 64 cases anecdotally reported, and of those 64 cases, 34 of the patients had no injury. What about treatment? Well, these are treatments that can be undertaken in the OR. I mentioned Trendelenburg position. CPB flows should be increased to force the bubbles through the circulation. Vasoconstrictors should be given to raise the blood pressure. Barbiturates should be considered to reduce cerebral metabolism and decrease the intracranial pressure. Hypothermia, either by packing the patient's head in ice or via the CPB circuit, has been advocated, again, to decrease oxygen requirements. And finally, ventilating the patient with 100% oxygen can promote air bubble resolution due to the solubility or by diffusion gradients, and will actually shrink the air bubbles. How about in the ICU? Well, there's been a number of regimens proposed by these authors shown at the bottom, and they appear in your syllabus booklet. Mannitol, of course, is quite appropriate. Steroids at one time were advocated, but more recent information indicates that steroids may not be particularly beneficial in the event of a massive air embolism. I'll leave that to the medical doctors to decide. Antiplatelet medications, lidocaine to decrease intracranial pressure, and finally strict glucose control to prevent hyperglycemia that can increase lactate production and development of acidosis. Other physical therapeutic tools in the ICU consist of hypothermia, increasing the blood pressure, hyperoxia, and finally hyperbaric oxygenation has been described and is quite effective. So finally, I'd like to close with a brief quotation that I've modified a bit. This was published by Sehu and colleagues in 2006. And what they said is massive air embolism remains a potentially, emphasis is on the word potentially, fatal and ever-present threat, even in this advanced scientific era, despite the availability of high-priority alarm systems and well-experienced perfusionists, surgeons, and anesthetists. I'd like to thank you for your attention, and